So hello everyone, can you hear me back there?
Yes.
All right. My name is Aditi Sethi, and I want to thank you, before we introduce everyone, I just want to thank you for spending your Thursday evening talking about something that's going to inevitably affect us all. Many of you have cared for someone who's passed away, someone who's expired, and someone who's been lost. And those are euphemisms that we use as part of our death language in our culture. And though we might find ourselves using it, I will be using the word death and dying very directly and openly, and I invite you to do the same if it feels comfortable. I know people that truly believe that in their lifetime, science will find a cure for aging and dying. Now, if you're one of those people, or if you are convinced you're not going to die, I'm glad that you're here, and I think that a little preparation can go a long way in supporting you and your loved one as you navigate the end-of-life care journey. There's a writer named David Kessler who's an author and public speaker and thanatologist, one who studies death, and he spoke at an Art of Dying conference in October of this year, and he made a statement that I had to reflect on, and he said, most of the people I know spend more time planning for a weekend getaway than they do their own death. Well, welcome. And I thought about that for a little while, and I pondered it to see if it was true for the people that I've cared for as a hospice and palliative care doc for the last 6 years. And I volunteered for hospice for 20 years prior, so 37, so when I was 17. Started working with hospice. And I would say that's probably true for a majority of people. And so some of this 4-part series is a hope to start preparing and start the dialogue and encourage you all to think about these things and get information about these things, these topics. The way this came about was this lovely lady here, Liz Frost, is a PA at IFMA. And she noticed that, there's, if you've been a primary care doctor, there's a very thorough history and physical exam and assessment that people fill out. And at the bottom, there's a checkbox that oftentimes says, have you filled out your advance directives? And she noticed, and you can feel free to chime in, she noticed that very few people had filled out their advance directives, or even had any interest in talking about death, and were often hesitant to talk about death. So over a beer one day at Pisca Brewing last August, we had this conversation, and this is what emerged: a 4-part, once-a-month series, taking us all through a journey of death, from what death looks like to how can we prepare for death, what are some of the things. End-of-life planning is not just living wills and advance directives. There's a lot more that goes into thinking about your death and a birth plan. And then the third was what are the options for the care of your body after you die. And then the 4th is grief and the way of grieving, kind of bereavement, holistic approaches to grief. So I'm going to let these folks introduce themselves. Again, I'm Aditi Sethi, and I work in hospice. I have been involved with hospice for 20 years as a volunteer, and then did a hospice palliative care fellowship, and have been working at an inpatient facility in town for 6 years. I'm very passionate about how we die, how we talk about death, how we prepare for death.
Hi everyone, can you hear me okay? Is the microphone good?
Yeah.
A little louder?
Yeah.
Okay, is that good? Okay.
Yeah.
All right, so my name is Briana Sabaj, and I'm a licensed acupuncturist and herbalist here in Asheville. And I've been here in Asheville working in my own clinic for about 10 years. I used to work at Mission Hospital. I practiced acupuncture there, and that's where I met this gentleman over here to my right. So it's lovely, to meet people through these connections and see what unfolds and unravels even years after working together. So that's a sweet connection and web that we create in life. So Aditi asked me to be here because I, on a certain aspect, can go into the world of death from a Chinese medicine perspective, which is amazing. And so my portion today is going to show you how to use holistic care, some acupressure points that you can use, some essential oils that you can use, and ways to look at death and the phases of dying through the eyes of Chinese medicine. And Chinese medicine is astounding, and who's had experience with Chinese medicine? Yay, I love it. So the people who have had experience, I hope that you find the value in it. If you haven't, keep looking for a practitioner that you might resonate with. It's kind of like shopping for a good pair of jeans, right? You know, a good pair of shoes. You got to find the right fit. So yeah, Chinese medicine is just basically looking at the cycles, and that's where I'm going to bring in the holistic aspect and the phases of dying, because to really connect to the natural cycles of death, looking at it from, I guess, how you've been experiencing it in your world, and in, I say your world, being different than the Chinese medicine world, and looking at it, you know, in it a little bit deeper in that aspect. So I'm excited to share that with you. And a little just personal tidbit, I have my own practice, and I have a 10-year-old daughter, which I homeschool as well. And yeah, that's about it, just so you know a little bit about me. Thank you.
Well, hello and welcome. My name is Greg Lathrop, and I come here in relation to the fact that my primary practice is as a registered nurse and a sacred passage doula, and we're going to talk some more about that in a little bit. That's part of what I bring tonight as well. And I met Briana, and I also met Aditi. We all converged at Mission Hospital, seemed to be the birthing ground for our relationship. And I have left Mission now, and I'm in private practice, and my practice is purely devoted to what we would call, or what I call, is the conscious dying realm. And that is, I teach in the Conscious Dying Institute, which was founded in Boulder, Colorado, and now we have an Asheville site here, where we teach and train about what it is to prepare as an end-of-life doula, or a sacred passage doula. And we'll get into that in a little bit, and we all have agreed that we are willing to free flow this, and if you have questions that come up, we've all said, feel free to ask, and we'll try to flow in an organic way. So having the opportunity to teach with the Conscious Dying Institute is where I am now. I started trying to count up so I could speak a little bit of a bio. I've been in healthcare 39 years now, and I found myself in many different chapters, and every chapter I was in put myself at the threshold of dying and death in lots of different ways. And the big chapters were air medical transport with trauma, and that environment in relation to living and dying, critical care, emergency care. Another big chapter was hospice. I worked hospice also for 12 years and had an opportunity to adjust my perspective. So, which was great. All of my other practice was stop it, stop it, stop it, stop it. And if I didn't stop it, I had to deal with my own guilt and my own stuff about what did I do wrong. And I was a lot younger. And then I realized as I evolved in my life and I was put in places to engage and embrace what is happening without trying to stop it first and foremost, And then actually allow for it to be. And finding the power and the medicine in that. And then as I entered into teaching about doula preparation and practicing in our life and using the principles of conscious dying in our life, whether you're practicing as a doula or not, the next step I found is maybe we can come to a place where we actually befriend death instead of just accepting. And so that's where I am now, in the opportunity to really look at what it is to befriend this part of life. It's not something that happens to life, in my experience. It's something that happens in life, as a part of life. And so I find it very important with regards to the beauty of our life to consider the opportunity to look in the mirror of death so that you can see how's your life going. Sometimes people ask me, well, what does it mean to be a death doula? You know, and usually my first response is a question. Well, how's your life? And well, what do you mean? And I'll say, well, how's your life going? Well, it's fine. I got a good job, you know, and kids are in college and got a house, got a roof over my head. You know, those immediate answers. And then I'll say something like, well, what would happen if you were to die in 3 months? How's your life? So that's a perspective. And often the answers are different. I'm in debt over my head, I hate my job, etc., etc. And so if I'm looking at a 3-month window, then things might look a little different. Anyway, so we could talk some more about that in a little bit, but that's why I'm here, grateful to be here, glad to see a full room.
Thank you, guys.
Thank you.
So yeah, please feel free to raise your hand, ask questions as we go through. I have a PowerPoint just because I'm going to present the biomedical perspective and how death and dying is done currently in our system. I also did the Sacred Passage Doula training, and I'm very interested in conscious dying and how our care for the dying can evolve and change. And we'll talk about some of the things that are happening in Asheville. People can chime in. And yes, we will begin. There is a quote that I just heard yesterday, and I want to share it with you before I start. It's by Gandhi, and he says, "Live as if you were to die tomorrow. Learn as if you were to live forever." So we'll learn about death as I'll share with you what I know. So I want to share this talk, The Myths of Death, about death and dying in America, came out of our conversation, Liz and I's conversation. But then there was a death fair, this community out in Pittsboro, North Carolina. It's abundancenorthcarolina.org. They started this thing around the Day of the Dead called a death fair, and they did their second annual one last November. And I presented this 15-minute, though it's not 15 minutes now, TED Talk style talk around myths of dying. So there are bullet points and it can move quickly, but I also added a few things for the purposes of tonight. So myth number 1, death is a medical event. So the fact is that with or without medical intervention, death is inevitable, it will occur. Death used to be a communal event like birth, and it was in the home, it was a religious, spiritual experience, and family members took care of their loved ones at home. And by the 20th century, death had moved into institutions, hospitals, and I read somewhere that early in the 1900s, the poorer people were the ones that were in the hospitals because they didn't have anyone to care for them with their diseases and the fear around their diseases, and the middle class and upper class folks would die at home. And so now the majority of people are dying in institutions still. And this phase of life, death and dying, is so distant from us. And very few people have personal experiences and direct experiences with death. So when it comes time for you or your loved one to die, it's oftentimes the first time people have seen death, have so many questions about death, and have a lot of fear around the topic. death is often perceived as a failure of our medical system, and those of you who are medical in our training know that the morbidity, mortality conferences, what did we do wrong? How did we, and to some degree that's valuable information if there's something that it was a medical error, but the kind of what that creates is a culture of death as a failure of our medical system, and not as a natural progression, not honoring that death is a natural part of life and part of disease and part of being human. So Greg spoke to this, and he'll speak to this more, but just like with the natural birthing movement that happened, there is a movement happening now, and it's been happening, and it's just kind of, it's evolving, but I think more than ever now there are people talking about death, there are more articles written about death, there's podcasts, there's documentaries coming out about how we die. And there are different terms for this movement. I've read natural movement, the death positive movement, and the conscious dying movement. So death is, even though death is a medical event, the care of dying people still rely heavily on us and not medical professionals. They rely on, and we'll talk about hospice and what hospice entails, but even with the best of medical care, you still need that family and community support to help you. So I just want you guys to take away that we do have autonomy. Autonomy is big in medicine. So we have a say in when, how, and where we die. There's some old data from the 1990s that say that about 80% of people, when polled, say they want to die at home, and about 60% die in hospitals, 20 in institutions, 20% at home. I think that's those statistics have probably changed. I think more and more people are dying outside of the hospital, maybe like 40, 50%. But still in institutions, whether they get transferred to an inpatient facility, or, there's a lot of transitions at the end of life now because people are trying not to have folks die in the hospital. So, but there's still a lot of admissions to the ICUs at the end of life. So something to think about. Any questions before I go to myth number 2? So death is always miserable and painful and horrific and so the answer is no. Natural death is not inherently painful, in my experience. And that's depending on the disease process, some people do have pain. And at times it can be very severe. For example, bone cancer that cancer that metastasizes to the bone can be very, very painful.
Aren't most cancers painful?
Not all.
At the end?
Depending on where it spreads, again. I would say certain cancers tend to be, again, if it's in the bone. Brain cancers can cause some headaches, but not always. Seizures are sometimes present. Cancer in the gut can be painful, especially if it spreads to your
Liver?
peritoneum. Liver disease is not inherently painful, in my experience. And Greg, you can chime in too. So I would say, again, there's so much variability. People's perception of pain is different. Experience of pain is different. But certain cancers can be painful. And depending on tumor sizes and, what they're pressing on.
You don't necessarily have to be just drugged into oblivion.
No.
No.
But a gentleman that
I've seen all of it.
personally, you've seen all of it?
I've seen every scenario.
Mm-hmm. Yeah, maybe you could share.
I'd rather shoot myself than go through the process. That's how horrible what I have observed. That's why I'm here. I don't want to go through that. I would just go before I would go through that process.
So you've seen painful deaths or knocked out deaths, sedated deaths?
All of the above.
Yeah. So I think that's where having these conversations, educating yourselves on the options that are out there currently, and really, really making sure that your wishes are known and understood, that will help. And having a doula, that's this whole movement of the doula, having a doula.
Someone told me a story about 2 people they knew who had actually tattooed on their chest DNR, because even though they had a DNR, it was ignored.
That happens.
And that's too bad. That's not getting your wishes taken care of. If it's an emergency, they're going to save you.
That's right. That's the default. Yeah. So with good hospice and palliative care, symptoms are often managed. And again, I'm speaking from the biomedical perspective, and I'm glad you're here to, Briana's here to talk about some of the other natural modalities to help with pain and symptoms. But with good hospice and palliative medicine, symptoms are often well managed. So death naturally occurs by dehydration. That's how we die. People naturally stop eating and drinking majority of the times in the dying process. Now, there are some people that have a hamburger the night before they die and they take their last breath the next morning. But in general, most people will decrease their intake of food and water. And that's felt to be sort of a comfortable way to go. And you know, when you get dehydrated, there are endorphins released, and it's kind of a euphoric experience. So there are some people that actually choose to voluntarily stop eating and drinking as a way to hasten their death. And I've helped people do that and supported them, and it's been very peaceful in my experience with good symptom management, again, depending on their disease process. So many diseases, and in your personal experience you might have seen, can you hear me okay? Lead to anorexia, the lack of interest in food, and cachexia, which is muscle wasting. So, you know, the classic picture of someone with cancer is the muscles here waste, temporal wasting, all their muscle mass diminishes. And that is part of the disease itself. The cancer itself is secreting hormones that tell the brain that you're not hungry and actually affect the skeletal muscle mass. So, contrary to what people think about end-of-life care, and I hear all these things. These are all from experience, from having folks come to where I work, and which is an inpatient hospice facility, and ask me these questions. Oh, I was under the impression you're going to not give them any food and water, and that's not the case. We don't withhold food and water from a dying person. People in the dying process often develop weakness in these neck muscles and can aspirate. So that's a risk. We always talk about the benefits and burdens of taking in food and water. You can thicken it, you can often thicken liquids, but oftentimes people can no longer eat and drink. It's not that we withhold water and food. A lot of information, and I'm just gonna keep going unless I see this. Okay. So anticipated death always occurs quickly. This is something that very few people understand in my experience. Death is oftentimes a process. We talk about the dying process. Where I work, we often get folks from the hospital who've been getting aggressive medical intervention, and there's nothing more medicine can do. Again, medicines fail them. And after all that, they come to the inpatient facility where they're going to die. And family members think it's going to happen the next day. Right when you take away antibiotics, they're going to die. Right when you stop dialysis, you're going to die. Right when you take away even ventilator, you're going to die. And that's not the case oftentimes. Sometimes it is, so it can occur rapidly, but oftentimes it's a process. Most people, so 90% of folks, and this is based on CDC guidelines, or CDC statistics, die after a period of gradual deterioration and in an illness. So 10% of deaths in America are sudden deaths. And this is some statistics, again, a little old, outdated, but 2015, about 2 million deaths a year, and life expectancy is about 78 years old. And then there's some other statistics for you. And the leading causes of death: heart disease, cancer, stroke, and COPD. Those are the leading causes. Again, accidental deaths, about 10% of those. So I want to go over this, the trajectories of death as we've seen with different disease processes. And this will give you some sort of sense of kind of the process of dying, really. So function being here and time here. So how functional you are. People with cancer, the natural progression of cancer is you're coasting along, you're functioning, and then you have a steady decline. Now treatment can affect that, but usually when you stop treatment, how quickly you're going to make changes, we don't know. But there's a steady decline, and you never quite get back to any kind of new baseline. And some of that decline can happen over weeks, months, days, minutes to hours. I've seen fast decline after treatment stopped from cancer. With end-stage organ disease, so heart failure, COPD, chronic obstructive pulmonary disease, you see, again, functioning here. This is how well you're functioning, and time. So with COPD and organ failure, you're coasting along. You have a sudden dip. We call them exacerbations. Oftentimes people go to the hospital, and then you get to a new baseline. It's kind of a stepwise decline. You get to a new baseline, and then you have another exacerbation, a pneumonia, an infection, and you get to another baseline. And you keep doing this stair step, and then eventually, as you see here, one event is going to lead to death. And so I couldn't find the last one here is just what they call prolonged dwindling. So elders and people with dementia, it's just this slow loss of functioning. It can go up and down, and then gradually you just decline. And that, again, dementia, end-stage dementia is a process. There's a scale, FAST-7C, that takes you through all the stages of end-stage dementia. And people don't understand that oftentimes, so that's something to be aware of. So again, just to review, sudden death, of course, you're coasting along, functioning well, and then you're gone, or, rapidly decline. And then terminal illness, organ failure, and frailty. Just so you can get a sense. Were you all familiar with any of these? Just curious. No? All right. Any questions about that so far? Stop asking. Okay. All right. It's possible. It is possible to predict exactly when someone will die. So that's another thing I get a lot of is, Doc, I have to go back to California, my job. I mean, can you tell me when my loved one's going to take their last breath? They really want to know. Can you tell me when it's going to happen? Should I go? Should I not go? And the reality is, it's a mystery as to when an individual will take their last breath. We've all seen, and maybe you guys have as well, your family members are holding vigil, like staying around the clock 24/7 for days on end. The loved one looks like they're dying. I think, oh my gosh, any moment now they can take their last breath, and they don't. And finally, everyone leaves the room, and their loved one goes. And it happened to my grandma. She had 7 kids, and all the grandkids were around her. Happened to you, I'm sure. And it's a phenomenon. But there are things that guide us and tell us that death is near, that can help us prognosticate. We think of things in terms of hours, or minutes to hours to days, days to weeks, weeks to months. That's kind of how we, as providers, offer some guidance. We always say we wish we had a crystal ball. So I just want to go over briefly some of the changes you might see with imminent death. And I divided it into early stage, middle stage, late stage. And imminent being that, okay, death is near, whether it's, again, that time frame, weeks to minutes, hours. So early stage, folks usually become bedbound. And again, a lot of this depends on the disease process, but in general, this is true. And how quickly people go through these phases is variable too. So people become bedbound, have less interest in food and water. They can be more sleepy, sometimes confused, delirious. As things progress, there's a change in mental status. Sometimes they can't clear their secretions. Again, the neck muscles get weaker, so you can't swallow and clear. And then coma, fever, changes in breathing patterns. Sometimes you can see changes in the skin color. And so the early stages, again, fatigue, weakness, less functional. Mom just doesn't want to get up and go out like she used to, 3 weeks before. Oftentimes in hindsight, you look back and you go, oh, Mom started her dying process 3 months ago, a month ago. And people can tell you, oh yeah. They get weaker, they just functionally can't do as much as they used to. Intake's a big one, so paying attention to that. And then delayed response is slowing, really a slowing overall. And then the middle stage, you can have, again, this can occur over variable time periods. You have a slowness of arousal. There's something called terminal delirium. In the literature, there's 2 roads to death. There's one that's hypoactive. People just sort of get more lethargic. They sleep, slip into a coma, and might go peacefully. A lot of those people can die at home without much medical intervention. There's another road to death, this hyperactive state, delirium, picking, restless, hallucinating, whether they're having visions of loved ones coming to get them, we don't know, but definitely picking, restless, disrobing, taking off their oxygen. Some people just can't get out of their, can't get comfortable and just want to get out of their bed and chair, even though they have no energy. I took care of a dear friend a couple weeks ago now. She died at 94, very ready to die, Buddhist, very, prepared for her death, I would say, but she had significant terminal delirium. Could not, she just said, take me, get me out, where am I going? And just this, all these, and if you start to pay attention, there's a lot of metaphors around this time too. I have a mechanic say, I need to go get my car, I need to fix my car, I need to get going. People who love trains, get me on that train,
Planes, trains, and automobiles. And taxis and horse carts and everything else.
It's such a mystery. I had a guy I took care of, came from the hospital, COPD exacerbation, remember, the dip, came to where I work, Solace, and we thought we were just going to tweak his meds and he'd go home. The day I saw him, he had his suitcase packed, sitting in a chair, dressed. I'm getting out of here. I'm ready to go home. I do not want to be here anymore. Talked to his son's like, he just got here, but he's breathing fine. Sure enough, died the next day in that bed. He was just ready to go somewhere. And you wouldn't expect, he didn't go through all these stages and changes, right? Not everybody reads the books. Dysphagia, again, dysphagia is just abnormal ability to swallow, urinary incontinence, bladder, bowel dysfunction, or incontinence, I shouldn't say dysfunction, it stops working. So yeah, dysfunction. And then the death rattle is a term that we hear, but we don't often use. It's just, again, all the secretion, saliva that you make just pulls in the back of the throat. So we often change positions, give medicines to decrease the production of secretion. In the late stage, you might see irregular breathing patterns, something called Cheyne-Stokes, where you're breathing fast and then you pause, and then irregular breathing patterns. Heart rate actually goes up, contrary to what people think. The body's trying to just preserve, organ function. So you see changes in circulation from feet up, cooling, purplish toes, modeling this lacy appearance to the skin. Not everybody develops that. I have people that come and are looking for it because their loved one before had it, but not always the case. Decreased urine output. So these are the things we look for to guide us in guiding others, right? And then eventually, most people become unresponsive. There's a time somewhere in there that's not in the literature, but there's this distant stare that people have, and they're looking somewhere else. They are between worlds, and it's such a mystery. All right. Talking fast. I get excited about this.
That's good, you're great.
That's what I know. So myth number 5. I have 10 myths. Hospice is a place you go when you're imminently dying. So I've actually had people who are very, very well educated that just don't know that hospice is not just a place you go. And it's just a matter of, again, having these conversations. So here we go. Hospice is how I look at it, is a philosophy of care and a structured system in place for giving that care, delivering that care. The majority of hospice, again, hospice being a team of people supporting you and a philosophy of comfort till you die, and we'll talk about some of the philosophy of care, but the majority of hospice care occurs in the home or nursing homes. So wherever your home is, assisted living, skilled nursing facility, or home. Some communities, and we're blessed to have 2, have an inpatient hospice facility where, again, there's certain criteria for being there. So just because you're dying doesn't mean you qualify to go to an inpatient hospice. An inpatient hospice is like a hospital for hospice folks. So there are certain criteria, and that's something people don't really understand. They just assume that if it gets too hard and they don't want to die at home, they can go to this facility. Not true. And that's where this emergence of residential hospices and things that are outside the scope of the medical model, right, where Medicare reimburses, that there are more grassroots things happening. And we'll talk about some of those. But so the inpatient hospice facilities have certain criteria to be there. Hospice is for folks who have a prognosis of 6 months or less. Doesn't mean people don't graduate from that 6 months and are in hospice for a year or two. That happens. And, but again, somebody has to say, yeah, would I be surprised if you're not with us in 6 months? So medical care is for comfort. So that the curative treatments are not continued, but the comfort measures are. Does that make sense? So if you're undergoing aggressive cancer treatments, hospice is not, you're not quite ready for hospice, or you're not quite on board with that philosophy of care to focus on comfort. There are certain treatments that hospices do, like if you have a hematologic cancer, a blood disorder, blood cancer, then you have a wedding you want to go to, but you've given up curative treatments, but you want a blood transfusion just to get you to that, give you a little boost of energy to get you to that wedding, then that's the sort of thing that you might do. But that is considered life prolonging. More of a comfort measure, but can be also considered life prolonging for a short time. But we'll do that defined trial period. The goal is to help people live well until they die. And that's essentially what hospice is all about. Not to hasten death, not to kill you with morphine, which we'll talk about.
What are the criteria for inpatient versus home? I mean, is it if the family is not capable of caring for the person at home, then can they go to inpatient, or are there other criteria?
Right, so what we call, this is the, again, medical languaging, caregiver insufficiency is the name for that in the medical world. Basically, we just need more support at home. We can't get it because it costs an arm and a leg to get home health or home care support, and we just don't have it. So caregiver insufficiency is the term, and it is not in a criteria for admission to an inpatient hospice. Four Seasons has Elizabeth House in town in Hendersonville.
Did you say it's not?
It's not. Dying in itself, in and of itself, is not a skilled. You have to meet skilled criteria. Just like if you had if you needed to be in a hospital, you have to meet certain criteria to be there. You need aggressive. You need aggressive management. If you're stable in the hospital, it's time to go. Right. Similar to an inpatient hospice. Some people come there. Some people, yeah, light. Some people come to an inpatient hospice just to get their symptoms managed and then go home. Others come there because their symptoms cannot be managed. So if your symptoms cannot be managed in the location you're in, you could go to inpatient hospice.
Yeah, because I had an experience with hospice at home, but, and they had, people came in from hospice once a day, and mostly what they seemed to do was just deliver drugs and, spend 5 or 10 minutes with the patient and then leave, and left it to the family to do the care. The family was up all night, damn near killed themselves trying to move a dead weight patient that they couldn't, it was horrible. And yet, I don't know if they would have allowed that person to go to inpatient or not.
It sounds like in that case, there must have been some symptoms that were needing aggressive management, so she might or he might have called it. Yeah, so if the symptoms were not being managed, in that case, the person sounds like they would have been appropriate for an inpatient hospice facility.
They would have been appropriate.
It sounds like it.
Yeah.
Again, if you're needing to do aggressive symptom management and you're not staying on top of it, and they're not comfortable, and you're up all night, then oftentimes you could come to an inpatient facility.
Yeah, well, wouldn't anybody at that stage at home, wouldn't it be pretty hard for the family to care for them?
So again, every death is different. There are certain people that need almost no medications at home, and families can take care of them. There are certain people that you just tweak their meds a little and they're comfortable with their duration. And there's others that are just revved up and they're not going to get comfortable without injectable medication or other modalities.
Or other modalities, yeah.
So I'd say in our community, there are probably 300 folks in hospice in the community at home. And we have 26 beds, and not all of them are always full. So a lot of people are dying at home comfortably. Again, with a lot of family support oftentimes. Yeah. Good question. So hospice does have a team of people that can come into the home. It's an interdisciplinary focus that includes emotional, spiritual, physical aspects of care. but still depends upon community, family support, because it's not 24/7 care. There was something called crisis care, which Greg actually participated in, that has been defunded. It's not funded anymore. It's too expensive. So there is a need for more, again, doula work, doula supports, and community support for the dying. And this is just a visual of all that hospice offers in terms of there's chaplain support, and they really do try to address the multiple aspects of being human, you know, spirit, the body, the mind. And yet there's more that can be done. There's a social worker that helps with logistical things, there's nurses, there's CNAs that come in the home, one of them's in the building somewhere, in the room, there she is, right? There are RNs, doctors can come to the home. It's a team, but again, it's minimal support in terms of the hands-on, you know, support. You have somebody 24/7 you can call, which is great, and that's a valuable thing. But really, it depends on your family and loved ones to do a lot of the care. And that can be taxing. Caregiver, the whole care for the caregiver is a whole other conversation that should always be addressed. Myth number 6. Hospice and palliative care. Have you all heard that term, palliative care? They're the same thing. That's a myth. So the fact is there are certain distinguishing characteristics, and I'll try to just briefly simplify it a little bit. So hospice, in medieval times, travelers, weary travelers would go to these homes, and hospice comes from the word hospitality, and they would come and get care. So that's where the term hospice comes from. But hospice, as we know it, began in the 60s as a grassroots movement for cancer patients. And so the traditional model of hospice is you pursue curative treatment, and then once you say, I'm done with aggressive treatment, you sign up for hospice. Right? And still, to some extent, that's true today in terms of hospice care. So palliative care, it's designed to complement curative treatment, essentially. So it expands this idea that our medical goals are just to cure, and it strives to include all these things: patient-centered goals, alleviating symptoms, comfort, enhancing function. So it focuses on quality of life while you're pursuing aggressive treatment. And a big part of what palliative care does is have difficult conversations. Palliative care folks have difficult conversations in terms of goals of care discussions. Let's say this happens, they talk to you like this, like if you're in the hospital with a COPD exacerbation, right, that dip, you might get a consult in the hospital to get palliative care involved to say, hey, what if this happens again? Do you want to keep coming back to the hospital? You know, so having these conversations, they often occur in the hospital. Again, community palliative care exists, but it's not as well funded. So palliative actually comes from the word that means, it's a Latin word that means cloak, and that there's some conversations about, well, you know, anyway, the goal is to alleviate symptoms, but that cloak, you know, has mixed.
But this is for somebody that is terminal.
So no, this is if you're, so I'll show you. So the idea is, in the ideal world, as soon as you get diagnosed with cancer and you're starting the curative treatments, whatever that is, holistic approaches or not, you'd have a team, palliative care team, that starts right then. So theoretically, right. So then as the disease progresses, palliative care would get more involved, and then once you decided not to do curative treatments, you'd go to hospice. That's the ideal transition. And I have seen that work sometimes beautifully. When I was in training, I saw a woman with breast cancer. She came into mission, had this massive tumor just growing from her chest wall, and she did not want any treatment. The doctors thought she was crazy, right? And she said, I just want to die. So palliative care got involved. I want to go home and die, live my life, and not deal with any of this. Palliative care got involved in the hospital, and in training, I got to follow her until she died. So palliative care got involved in the hospital, had these conversations. She goes home with hospice, but her symptoms got so unbearable, the odor, the pain, you know, and she ended up at Solace, and she died peacefully there. So that's the ideal. I met a guy too who had lung cancer, and he walked into this is an outpatient palliative care clinic, so that exists, but they're not as easy to get into. comes in, I'm a golfer, I can't golf, I have cancer, lung cancer, I'm gonna die. I don't really need to be here, but I just wanted to get a relationship with you. And so got to see him. Palliative care comes in, even though he wasn't really sure about curative treatments. There wasn't much to offer. But he got involved as soon as he got diagnosed. Ended up not doing curative treatments. Got into hospice, died in hospice. So even if you Google hospice and palliative care, they use the terms interchangeably. That's very confusing. So one way of thinking about it is hospice care is palliative, right? Palliative means to alleviate, to comfort. Hospice is palliative, but there's also something called non-hospice palliative care, right? So palliative care, what I personally like to just keep it separate. Hospice is 6 months or less. Palliative care can occur when you're pursuing curative treatments. You don't have to say, I'm done with curing my disease when you get palliative care involved. You can do both. So that's just one way of looking at it. Does that make sense?
Yeah, it was not explained to me very well at all in a hospital. And I asked directly, are we talking about hospice? Oh no, no. This is not hospice. He's going to be fine. And they were saying it was palliative care, and I thought there was a distinct difference.
So
And what they denied him and his family was the opportunity to come and be with him if this was going to be the end. And that was never said.
what was the disease or hospice?
He was being treated for cancer, and they gave him too much radiation and burned up his insides. That's the short version. But still, those treatments had stopped. We were led to believe that he could still recover. I mean, eventually cancer was going to get him, probably, but they didn't explain the time frame. He had 4 children all over the country that should have been able to have been there. And they kept saying, he's fine, even though he was on IVs and not eating and not drinking and all the other signs that I've sent for him. So in other words, the hospital, this was Cleveland Clinic, by the way.
Wow. So that just speaks to me, what I hear is providers still have a really tough time talking about this and accepting that partly they are optimistic, right? They're in the hospital with aggressive treatment. Maybe they truly believed he would make it out of this dip. There's just no way of knowing sometimes, But I think, again, talking about death openly.
But that's where the distinction in terms, and I specifically asked about that. Should we call in hospice, to see, did he want to stay there? Did he want to be home? Did he, in the hospital? And that they don't explain it well.
So I think having an advocate like yourself, the fact that you were there even asking, and hopefully they heard you on some level, maybe they didn't deliver the news.
I had a meeting with a lot of people at the clinic after he
That's
died,
great.
but it was like, these things happen, They don't want to be sued. Unfortunately, I have a very negative feeling of dying in the hospital and standard medical care in general, which is why I'm here.
Yeah.
I mean, I'll do
it's good to
anything
know, right.
to avoid that type of process.
In my training as a med student, I saw so many terrible deaths, painful. People were just not aware that their loved one's dying. Similarly, no one was telling them, hey, this guy could be dying or is dying. So there is, So there's that, that reality. So myth number 7, and thank you for sharing. Hospice kills people with morphine. That's a big one. So, using morphine to hasten death in America would be euthanasia, which is illegal. So we do not kill people with morphine. If you titrate medicines like morphine slowly and effectively, and we usually use it for pain or shortness of breath, it has not been shown to hasten death. Respiratory depression is often rare. if you titrate slowly. And in general, hospice just does not kill people, right? We allow death to occur naturally in a normal time frame in as humane a way as possible. Now, the question of whether we have a lot of over-medicated or medicated deaths, that's a different conversation. There are some people that choose, you asked about, are you just going to be knocked out? There are some people that would rather be sedated than be in pain. Other people, I took care of a guy who had a brain tumor, just went to the ER and couldn't find his words, found out he has a mass, said, I'm just going to go home and die. So 7 weeks later, he dies with very minimal morphine, but he used it just once or twice for a headache. But he didn't need it a lot, you know? And he'd done the POA practice, the Tibetan Buddhist practice, did not want to die medicated, wanted to see the light, you know? Mm-hmm. And so he did. But other people, you know, would rather just be knocked out. My dad, who's a doc, would rather just be given 20,000 milligrams of morphine and help him die. And we can't do that. But to each their own. So it's true we use pharmaceuticals in the dying process. Oftentimes older, cheaper drugs. You'll hear the medicines that we use. Morphine, Ativan, Haldol are commonly used.
What is Dilaudid?
Dilaudid is an opioid like morphine, a little more potent.
More potent.
So opioids for pain and shortness of breath. Ativan is often a good medicine for anxiety, and Haldol for the delirium, picking, agitation, right? We tend to use the older drugs for many reasons I won't go into. They can be given different routes. That's one reason. You can give it under the tongue when somebody can't swallow. You can give it in a port under the skin, so you don't have to do IVs. You can give it rectally. You can give it orally. Multiple routes. But that's often a concern. These drugs I've read about, they're old, they're dirty, they're cheap. And hospice is a capitated program. You get a certain amount of money per day, per person. It's not like the more you give, the more money you get. It's sort of, you get a certain amount of money to take care of folks. So older economical drugs that work is what we go to. Any questions? Oh, so aid in dying is a whole nother conversation. And I mentioned aid in dying. Aid, like physician aid in dying, or physician, the term that used to be used is physician-assisted suicide, physician-assisted suicide. Now it's called PAD, physician aid in dying. It's a little less loaded emotionally and more neutral than suicide. In our state, so there's a lot of legislation going through. It's not legal in our state, but aid in dying is legal in multiple states now. Yeah, it's exactly. There's so many bills. I heard Alaska has a bill going through the House right now for aid in dying. So California, Washington, Oregon, Montana, Colorado. Colorado, Vermont, DC has something now brewing, or has passed.
Coincidental.
New Hampshire, yeah.
So if you wanted physician aid in North Carolina, you'd have to get to another state, essentially, right now.
You'd have to be a resident.
Or
You have to live there.
Oh,
At least a year.
then you gotta go and establish residency.
People did that. Brittany Maynard, I think, did it, right? She moved. The woman that was in the media for a while. I think she moved to get residency in Oregon. I think she lived in California and moved. Anyway, she moved.
But that's different than hospice, right? So you could stay in North Carolina and just choose to go to hospice, and then they can help you, right?
We can't hasten death.
Not a secret
Oh,
handshake.
not hasten,
Huh?
Not a
but,
secret handshake you can do.
No.
so you can't hasten death, but you can make somebody comfortable.
Aid in dying is actually you take a pill that leads to your death before the natural
Okay,
disease
like
would
you've got
progress.
diagnosed with cancer, I don't wanna go through with this, I want a pill.
Yes,
I'm out of here.
yes.
what
And that's
that
legal,
is.
and people ask about that, and I definitely normalize it. I hear what you're saying, I understand why you're saying it, and in some states, I could help you with that. That's where, in this state, voluntarily stopping eating and drinking, you can look it up, VSED, VSED, voluntarily stopping eating and drinking is an option. It sounds awful, some people say, that sounds like an awful way to go. But if you're already dying,
Uncomfortable.
it's actually, it hasn't been shown to be uncomfortable. There's some people that, there's some people that just can't handle the thirst and they drink cupfuls of water, and that's not VSED because You have to completely stop eating and drinking. Some ice chips, some mouth swabs, some care will make you comfortable. And for some people that's enough. But that's the only thing close to hastening death that we can support.
It's actually a natural progression. And if you're following and you're really attuned to what's happening with your body and you're losing your appetite and you're coming to a place where you're wondering about how much longer you can do this, it becomes a very conscious option. And your body's actually already telling you, might be a good time to stop. As a matter of fact, sometimes what happens is it goes the other way in our fear of death, and that is if you stop eating, then I'm not really comfortable with you stopping, being a family member, as an example. I wished you would eat. You know, you got to get your strength back, you have to recover. And all of those things we've heard our whole life. And it relates to a fear of death, and we know that if you stop eating, you're going to die. And so that's a real phenomenon. But what I've noticed in that, and what Aditi was talking to, is when someone follows that natural progression and says, I'm ready to stop eating now, consciously, still very much awake, still in their body very much, they could probably eat a little bit here and there, but they really are doing it just out of habit more than enjoyment. And so there's an opportunity to really look at that and say, could this be something I could do? And what I've witnessed is that's probably as most conscious as you're gonna get, because you're just moving with what's happening, and it turns into a vigil, and people are with you, and you're engaging in this practice. I'm going to stop eating and drinking. And there's documentaries about it, watching people go through this process. And my experience was it was more comfortable than trying to force food and liquids in a body that is rejecting them anyway. In my experience.
And people do force feed, quote unquote force feed, you know? I mean, I've seen family members till the last breath try to get food in their loved one. So, yeah. There's something else I was going to say about B7, but it slipped my mind. Yeah. Can't remember. All right. Talking about death results in death coming sooner and causes more distress to the dying. Can't tell you how many people take me out of the room. Mom does not know she's dying, and I don't want her to know. We can't talk about this, right? So, what do you do with that? And then I walk in the room, and kids are out. Mom says, I can't really tell my kids. I know I'm dying. So, my experience is talking about death openly, and I'm talking about with people who are dying, creates an opportunity for everyone involved, you know, for many different things, and does not hasten their death. Most people who are dying know they're dying. And they often try to protect loved ones, especially moms, I've noticed, from the pain and anguish that the kids might feel. Contrary to causing more distress, it actually can alleviate some of that sadness and emotional angst if you just have an open conversation. It gives a sense of peace, and especially if you give them time to talk about their experience. So one thing that when someone looks me in the eye and says, am I dying? One thing that you can do is say, tell me more, why do you ask that question, or what do you think? And give them a chance to talk, if you don't feel comfortable asking them yourself, or talking about approaching death yourself. Now there are some people that have no interest in talking about death, and doing so would be stressful and anxiety provoking, so we just have to meet people where they are. But giving them a chance is something that we can do. They don't go there, that's fine. A lot of people don't. My, I don't know how she's related. My husband's uncle, his wife died of breast cancer, and knowing what I do, she didn't talk to me much as she was dying, because she was dying at MD Anderson, pursuing aggressive treatments, chemo, and had pneumonia and respiratory failure, died quickly. She did not want to go there, did not want to talk about death, did not want to think about the possibility of not being with her grandkids and her 2 daughters. And that was okay. I didn't force it, right? I mean, you can't. So meeting people where they are on their own terms is key. And Greg often says, I would love for you to tell your story about when is a good time to talk about death. So you get diagnosed with cancer. Or no, I love the way you do it. I'll leave it to you. Thanksgiving dinner table, why are you talking about this? You know what I'm talking about? And you always say, like, if you bring it up at Thanksgiving, then if you bring it up when you're diagnosed, don't talk about it now. I gotta do that.
Yeah. Oh, well, we have a syndrome in our part of the world, and that is, there is this reluctance to engage in the conversation at all. And what happens is, if I have the audacity to tell you as my family, my children, or my parents, or whoever, what I would like to have in my life before I die, the first response is, why are we talking about this? And it's inevitable. Is there something wrong with you? Is there something you're not telling me? And then the last statement is, I don't want to talk about this. Related to these myths, there is an interesting undertone in our culture that if we talk about it, it's going to happen. Well, my sense is it is going to happen, whether you talk about it or not. But then here's the other side of the story. The other side is we have a diagnosis. We have what is called a terminal illness. We are even a hospice patient. And if I were to say, I would like to talk about what I would like before I die in my life, the response is, why are we talking about this? You have to keep fighting. You cannot give up. I don't want to talk about this. And this is a real dilemma. It really is. Because this is what happens when we look at, and those of you that have experienced, I know you've expressed yourself about your experience, but those of you that have, who in here has experienced being with someone very close who is dying or has died? Almost always, it's almost everyone, of course. Those are our teachers. They have showed us something. They've given us perspective. They've given us some information so that we can be more clear as I listen to you about, I'm not doing that, and I'm not doing that, and don't even think about that. They're our teachers. They show us some things about what we want in our life. And so this myth about that, we have to move through that, and we have to talk about it anyway. And if you want to envision this, we do our best to envision the way that we want to live, is what we're talking about. Death is just a moment in time. It's one moment. Everything else is life. And so how do we want to live our life? We have to talk about it. We have to talk about it with people that we really trust. And that may not be your children. It's good to talk to your children, but if you're talking about people making decisions for you, you know, there's a new term in our elder orphans. Have you heard that recently? Elder orphans.
Elders with no kids still?
Well, or the kids are in another country, or they're just alone. And I was talking with a woman about that, and I said, who is your power of attorney? Who's your healthcare power of attorney? She said, well, my son is. I said, well, where does he live? You know, he lives in Canada, or where, it was somewhere, it wasn't even this, no, it wasn't even this continent, it was somewhere else. And I said, how would that work for you? Would he come when you need some help? Well, I think so. And does he know what you want? Does he know what you want? If you say, I want to stop eating and drinking now, will he honor that? And so often, that's not the case. Because we have attachments. I'm not going to be the one to let my mother starve to death or whatever. So it is the conversation, and we do have that hurdle to get over, which is the fear that if we talk about it too much, it's just going to call it in and make it happen. And so we have an opportunity to talk. And this is still in our culture. Why are we talking about it? I don't want to talk about it. And so that's is why this is happening.
That's right. It reminds me of that saying that talking to teenagers about sex won't get them pregnant. It's a similar thing, right? So, anyway, speaking of children, we should shield children from death. Young children, like this lovely 11-year-old, shouldn't be around this conversation. It's initial kind of feeling. So, true for children who are dying of a terminal illness, and for those experiencing the death of a loved one, they tend to be more open talking about this than we are. And they learn also, and the flip side is that they have this innate interest and openness, but the flip side is they learn how to cope with the reality of death from us. So, some tools for you if you're dealing with the death of a loved one in your children or children are present, normalizing the fact that everything born dies, including us, teaches children about death. What matters most is how we listen to them, how we feel when we speak, and then what we say. So oftentimes parents are just, they don't know what to say to children. But again, if we just listen to children and have our own comfort coming through that interaction with death, or comfort or discomfort, but just honesty and openness, that's often more important than what we say. So again, using clear, direct language, not euphemisms, like they've gone to sleep, they're resting, because that can cause fear for children going to sleep and resting, right? They'll think they're going to die, or they are dying. And another way, again, like the Day of the Dead celebration, bringing some of that back into our culture, where we honor our ancestors and bring them into the present, and reassuring them that love really never dies. And then acknowledging grief and talking about grief openly and keeping that connection alive. So the last myth, number 10, is that when my time comes, when it's my time, I will be prepared for death. I'll have it all in writing, it'll all be figured out. The reality is, most people do not have advance directives in our country. 26% of people. And there are many reasons for that. And now advance directives, when you hear that term, we're talking simply paperwork that says, I have a healthcare power of attorney, this is my healthcare power of attorney, and this is my living will. Sorry. Good? So advance directives are simply, they're legal documents. We'll talk about that next month. We'll go in more detail. Who your healthcare power of attorney is. Who do you want to appoint? If you can't make decisions for yourself, who is that next person going to be that will support my wishes and honor my wishes? And then living wills. What do I want? Do I want do I want to be intubated? Do I want CPR? The DNR question. Now, there's so much more to thinking about and being prepared for death than just those documents. You know, we think that that's all that goes into this conversation, but really, it's like what Greg talked about. And there's this whole concept of a death plan, like we have birth plans. You know, what would that look like? What kind of music do I want to listen to? Where would I want to be? Who do I want around me? What friends I had somebody already appoint me to be on their team, you know, of people that they can call. And it's really a matter of getting community engaged and supporting you through it. What kind of food do I want to have? What kind of smells? What kind of smell do I not want to have? Who do I not want to be there energetically? So that's a beautiful plan you can lay out. Do I want candles? Do I want aromatherapists? Do I want acupuncturists present? You know, going into more detail than just do I have these two documents.
So I want to hear television, no.
Good one. Yes. Some references. That's that. That's a lot of information.
Thank you.
Useful, some of it.
Very, thank you.
So we'll pass it along to, should we go? Yeah?
So, using holistic care through conscious dying, that's what I'm going to talk to you all about today, okay? Can everybody hear me okay? Okay. So, Chinese medicine, I want to first introduce you to the ideas behind Chinese medicine and how Chinese medicine looks at the body, life in general. So basically, I heard a term and I ascribe it, I guess, to everything now. It's just very succinct and it can describe Chinese medicine in a nutshell. But I heard it years ago, and it's an acronym, I guess, when you take the letters of the first. Okay, so generating, organizing, and destroying. God. Generating, organizing, destroying. Okay? Cycles, right? And that's what life is. It's all cycles. Everything. Everything has cycles. And so the idea behind Chinese medicine is that, you know, there's the idea of cycles, but within that cycle, you know, you look at the outer and then the inner, right? Everything that happens outside of us happens within us. And so we are the microcosm of the macrocosm. So we're based on the idea that the human body is a smaller universe within the larger universe. And we'll look at this and then we'll go into the idea of cycles. Okay, we are not separate from nature. We are nature. We aren't different than nature. And so often, sorry, I need to stand. So often, now I am of the belief, like I said, I worked at Mission Hospital for a good year and a half, and because I felt like acupuncture and Chinese medicine was greatly needed in that area, and I'm of the belief that, you know, there's a place for Western medicine, of course. I definitely used it when I was pregnant, and I had 3 complications with my pregnancy. I ended up having my baby all natural in water birth after like placenta abruptia, all these things. But I use the power of the body. We are born with our own pharmaceutical system within us, okay? And so I use the power of the body and the natural tools that I had around me, and I went through all of those complications, and I still had my baby all naturally. But I was in the hands of Western medicine when I needed to be, and then I brought it right back to nature, because that's what we are. And so if we can provide ourselves the tools, then we can approach life and all processes of life from birth to death with natural tools, right? So just like the earth has rivers and streams, our body has rivers and streams of energy. And so in Chinese medicine, we look at the organ systems, like every organ system has a certain energetic meridian to it, and a certain function, a certain emotion associated with it, a season. So that's where the cycles start to come in. And so what we do in Chinese medicine is there's 365 points in the body. I don't know which slide I'm on sometimes. I have a lot of information in my brain and it just kind of comes out. Let's see if it's on the next one. Nope, I'll go back here. Okay, so we have 365 points in the body that's in traditional Chinese medicine, and there's a lot of different, like I'm learning under this family that has, it's not traditional Chinese medicine, it's classical Chinese medicine, which was before the Mao Zedong era, which, you know, was the communist era. There was classical Chinese medicine, and then they started westernizing the Chinese medicine approach. And so, but the classical looks at things in a very different way than traditional Chinese medicine. And so my point being is that the 365 points, like what I've learned also, I added like another 500 to 700 points in addition to what I already knew, okay? And you use these points, every point has about 3 or 5 different functions, and every point is associated with a certain organ system. And so we look at what organ systems are involved, what emotions are involved, where the pain body is. We look at the whole entire person from what their birth was like all the way up until how they're showing up right now. Because everything in your life, even from when you're in your mom's womb, plays a role into who you are right now. And Chinese medicine looks to unravel that and help you along the way, okay? So my job is to help people understand and to kind of connect and reconnect to the body and reconnect to how we can look at our body like its own natural pharmaceutical system and use the natural tools that we have. Okay. All right, so wuxing. This is basically another word for the 5 phases. And in Chinese medicine, there are 5 phases, or they are basically the continuation of the process of life. Who's familiar with the yin and yang symbol? Okay. So you've got the yin and yang symbol. You've got the swirl with the black and the white. I don't have can't draw it, but you know what I'm talking about, right? Okay, so there's the black and then the white, and then there's a little bit of black within the white and a little bit of white within the black. So the cool thing about the yin and yang symbol is a Taoist theory, and it signifies life. It signifies everything about life. There's one, right? We're all one. There's the unity. And then there's the duality. There's the black and then the white. There's the separation. And then there's the cycle. It's a circle cycle, but the separated parts cycle into each other, right? And then there's a little bit of yin within the yang. The black is yin, and there's a little bit of yang within the yin. So for example, yin is represented by black, by night. It's getting yin time at night. It's women, dark, winter time. We're moving into the yang time of the year. We're moving into the spring time, the active. Okay, the yin is slow moving, the yang is fire. So midday is yang. Now, if we're, at the change of a day, we have a little bit of yin in the yang, so that is, I always get confused about this one. When it's like dawn getting into the rise of the day, you have more of a little bit of yin within the yang, because the yang is starting. So you can see how everything is cycling, and that describes everything in life, and that goes back to the generating, organizing, and destroying. And so we're going to see how this plays a role in the dying aspect of life. Okay, so there's no true beginning and no true ending. There's constant motion within the cycles. Am I blocking you, Greg? I'm sorry. Okay, so each phase corresponds, I told you about that, to the quality of energy, an organ, a season, an emotion, a color, a flavor, and we'll tap into that a little bit. But we've got the wood, fire, earth, metal, and water. So this is just another chart that goes to show the different elements and the different organ systems involved, the different emotions. Now there's literally in my Chinese medicine text, there's pages of like a list of everything that you can come up with as far as cycles, like the direction, the longitude and latitude, and yeah, it's kind of crazy what you can decipher with the 5 phases. But basically you can see, so in every element there's organs associated with it. You've got the liver, I won't move around, sorry. We got the liver and the gallbladder, and we're in springtime right now, right? So we're in the liver and the gallbladder season. So people with a lot of allergies, a lot of issues with watery eyes, well, this is the eye season. This is the time where things come up and out, right? So that's the movement of the liver. The liver's job is to regulate the chi, or the energy, the life force in our body. And so up and out. So people who have a lot of allergies might have liver issues. And when I say organs, think of Chinese medicine. Yes, there's an overlap in Western medicine, but it's different mechanisms, okay? So liver gallbladder issues for this time of year, it's going to show up. So these are just different ways to look at the elements with their corresponding organ systems. So for people who are getting irritable, and often, you look to the liver. For people who are, that joyfulness, that robust joy that some people have? People have heart fire. That's what's called heart fire. If somebody talks a lot, and they're very joyous and boisterous, they have heart fire because it's just a lot of heat coming up. Okay, that's how we diagnose and assess people. We don't, if you've got one label in Western medicine, I've got probably about 5 or 6 different patterns that I can come up with of why your body is doing what it's doing. So that's kind of like a reflection, it's a good reflection to look at the 5 phases. For people who worry a lot, then they're going to work on their spleen and their stomach. You're going to need to reflect on that. And grief and sadness has to do with the metal and the lungs, and water is fear. Winter, that's the kidneys, okay? So we're going to reflect on this, and then the cycles of life, cycles of, death, conscious dying. That's why we're here. 30. Yeah.
What about the sixth sense of being able to sense energy in your surroundings? Because it seems like, especially in the dying phase, that would really be even more exaggerated, perhaps. Is that considered in Chinese medicine?
Yeah, so that brings us a very good question. That actually brings us, so there's different phases, and I'm gonna move through on a quicker level to make sure that there's enough time and space for you. But when we talk about the different phases of dying, there's the outer dissolutions and the inner dissolutions. And so when the outer deal more with the human, and then the human aspect of letting go of the physical body, and then all of the physicalities that happen to the body. And then there's a transition where it goes into the inner dissolutions, where you start seeing things and staring off in that distance to who knows what people are looking at. So there is a point, a catalyst point, and the phases are actually we're going to talk about that right now. Okay, so they don't go into the five elements, more of the 4 elements. So we're skipping metal here. So those 8 stages of death, which is the outer dissolutions and the inner dissolutions, and those are combined 8 stages of death. And so the dissolutions are where, like I was talking about, the layers of the consciousness are peeled off. So you're going from your humanity to your spirit self. So the first 4 are the earth, water, fire, and air, and the last 4 are the subtle consciousness. Okay, so over here, we're going to talk about, and this reflects on Aditi, what she was talking about with all the body, how the body is going to show up, and this is a way to explain it. So how, we talked about earth and the spleen and the stomach, and the earth in Chinese medicine is responsible for the muscle. It's responsible for the integrity of our muscle. The spleen and the stomach, it's how we get our food. So we get qi 2 different ways. We get it from our parents, and we can't ever replace that. What we get from our parents is what we've got. But we can conserve that and preserve that, which is the basis and foundation of Chinese medicine, so we don't start to dip into that. Because once we start to dip into what our parents gave us on an energetic, like foundational level, we start aging poorly. Like if we live a hard life, stress, lots of medications, you know, stress, life, you know, but we start dipping into, but our postnatal chi, how we get our chi is through our food that we eat and the air that we breathe, okay? And then our body takes that, rottens and ripens it, and creates chi for our whole body. So the spleen in the stomach is in charge of taking the integrity of our food and using, and it's associated with the muscles, the integrity of the muscles. So the first thing to go, you know, is the earth, the spleen, and the stomach. So the body starts to become weak. There starts to become muscle atrophy. That's where you see the temples of the, you know, of the head and the face and the sallow complexion. It's color yellow, right? We talked about earth and yellow, so it's the color yellow. So people are gonna be turning yellow. And so this is where people could see this shimmering mirage of sorts. And then you start moving into the water level. So that's the kidneys and the bladder. The body fluids start drying up, and then you start losing, because the kidneys in Chinese medicine is the water, right? And if we're not astringing and holding with our muscle, then we're letting it loose, right? Our muscles are already weak, they're prolapsing, so we're gonna let things go. So and your tongue, right? The tongue is your muscle in your body, right? The only muscle you can see in your body. And so that's gonna be, you know, no tongue movement, because there's not enough force, not enough chi to move it. So things are going to be starting to disseminate in that way. So it's going to go from earth to water, then water to fire. And then the fire comes in, and then everything dries up. The fire's starting to be put out. Okay, so you've got the mouth and nose drying up. Aditi was talking about the limbs becoming cold and going more like into the center, and that's what's happening over here. The mind, while it was agitated before, is starting to become very fuzzy. Yep. And then you have that loss of recognition. Okay, and then so the fire goes into the wind, and so some people will report seeing like shimmering fireflies over fire. So that would be that stage of life or death. And then the wind is the next, and then that is the transition between the inner dissolutions. And so they can't move anymore. There's decreased breathing. The in-breaths are short. So that's like the Cheyne-Stokes breathing. And then these are the inner dissolutions. You've got this appearance of the white light going through the crown down to the heart. So your thoughts and emotions dissolve. And then you've got the increase, so you've got the red light through the lower dantian, which is right here, and that's going to meet, and it's going to go up to the heart, and they're going to meet. And then you've got full attainment, when then there's nothing. And all of your drama is like, right? Your human drama. And then you have the light. Then there's the light. So these are the phases. I'm going to take a hop, skip, and a jump so that Greg can talk. And I'm going to talk about essential oils super quick. Okay? So the natural solutions at your fingertips. So I'm gonna just actually skip all this. I'm gonna talk to you real quick about this. I'll probably spend like 30 seconds. But essential oils, I use them all. I've been using them for 5 years. I'm an herbalist for 15 years. Been practicing acupuncture for 17. But I know I look like I'm 5. I'm really not. I'm not. I am over 40. It is true. It is true. So it's because I use essential oils and Chinese medicine. So essential oils, it's basically 50 to 70 times more potent than the herbal counterpart. So I love using essential oils, especially because it's very user-friendly. When you know how to use them and you have the right instruction and you have the right resources, it's really easy to find all of those things. I can help you if you need. But when you have that, it's very user-friendly all across the board, from the littlest ones to the not so littlest ones. Okay, so that's what it's just palpable for everybody. It's not just for the person who's passing, but it's for the family and the friends around them too. So they're very highly concentrated, so you don't need a lot. Okay, a little goes a long way. And there's definitely cautions and contraindications. You want to be mindful with the skin. I'm not going to go into all that today. That's not the class for that. But if I had more time, I would, because I talk a lot. Okay, we're not going to go over that. Okay, so topical applications for essential oils. We've got foot reflexology on the bottom of our feet, and I also use a lot of acupressure points. So if you look at the foot reflexology and you can learn what kind of oils can help, and I'm going to go over briefly later, then you can put the oils in the corresponding points and give nice foot rubs. You can also do it on the hand if the feet aren't accessible. You can do it on the hand. You can do it topically on the part of the body. You can use diffuser. Okay, they say that you cannot heal emotion without scent, because when you smell the aroma, it goes right from your olfactory senses right to the limbic system. There's no barrier. And the limbic system is our fight or flight regulator, our mood regulator. So it controls a lot in our body. So when we're working with emotions, we want to have our fight or flight. We want to have the nervous systems worked with. So and aromatherapy, essential oils, as it's coming out nowadays, is huge for that. So I've worked a lot with essential oils and grief in this process. Okay, so some common acupuncture points. The chakras, the 7 chakras. You can use the essential oils on the chakras, being obviously not necessarily on the first chakra, but on the feet for the first chakra or the legs for the first chakra. And there's many ways to use the essential oils. But using the chakras and the oils with the intention, the essential oils every oil has an emotion associated with it as well. So getting into learning about the emotions is a lot of fun. So some common acupoint locations would be the pericardium 6. Right here, this is a very common point, and we know it from the C-bands, right, that we've got. So we've got C-bands. This is a calming point, and I love this point over here because it does a lot of things. It calms the mind, it calms the heart, and it calms the stomach. So you're getting all of these 3. So just simply putting on the wrist, it's going to expand the chest, open the chest for breathing, for that shortness of breath, for that, if someone has grief and they can't take a deep breath in, that's going to help with that. Family also grieving, things like that. Another one would be over here, yin tong. That's for restful mind, and also to open up our destiny, our spirit world. Okay, so putting a spot there. Sanjiao 17, right behind the ears. That's a great place to do it, to get into the lymphatic system, to help with balance, to help with neurological function. Also, the back of the neck right here also helps support the brain. And elbow creases, like wrist creases and elbow creases, are similar, where they're going to open up the chest, help support the digestion, things like that. Okay. So I'm going to not go through this because I want Greg to talk. Okay, so I'm just going to lay this out there. There's a lot of essentials oils out there. I start with a base set of oils for people when I help people learn how, because there's a base set to learn from, because there's so many uses, it could get overwhelming. So having certain ones at home, you can apply like for hundreds of different uses, okay? So more bang for it, right? If you have one thing that can apply for a whole bunch of things. So, but here in this case, supporting the emotional process of dying. So we've got shock and trauma, helichrysum and juniper berry. Juniper berry is the oil for fear, and helichrysum is the oil for pain. So if somebody's going to hear that, when they first hear they have cancer, or they first hear that, they have this illness, then they have shock and trauma, or their family has shock and trauma, or friends. And so you can help support that process by using oils like these. You've got anger, lavender, geranium, cardamom, and thyme. Those are all very helpful to work with anger through that process. Grief, bergamot, lavender, and respiratory support oils. Again, because we're working with the lungs, we want to support the lungs for grief, because the lungs are associated with grief in Chinese medicine. Ancestry. So when you're working with dying, you want to work with the ancestors. You want to make sure that they're ready. So you want to work with any of the furs, Douglas fir, white fir, Siberian fir. They're all ancestral oils, and you can work with them. I like working with sandalwood too, because it's the oil of sacred devotion. So sandalwood and Douglas fir are really nice together. And petitgrain is also ancestor work. Peaceful and meditative oils, I talked about sandalwood, frankincense, any of the biblical oils, really, the myrrh, cedarwood, and frankincense cross the blood-brain barrier, so that's really nice to help, to help whatever process they're going through. Marjoram's a muscle relaxer, but it's also the oil of connection, so you want the person to feel connected. And Roman chamomile is the oil for spirituality. Love and light. Melissa is the oil of light. Juniper berry is the oil of dark. Melissa is the oil of light. So it's really cool to use. I actually use them together in tandem for yin and yang, right? So, and then we've got rose and geranium. It's just love and trust, okay? So to love and trust the path that you're on, and the way that you're passing, and hopefully, it's an easy and graceful process. Okay. Do you guys want to take? I don't want to take, because you have 30.
I don't have a suit.
We'll do 10 minutes.
10 minutes.
Yeah.
So yeah. So if you want to take pictures of that, you're more than welcome. Or I can talk about that, or I could leave it up.
Remember, the slides will be available. So
Okay.
remember the practice.
Yeah. Yeah. What was that? What was your question?
What company do you get your oils?
I use doTERRA essential oils. And I'll leave that up too. And what was my next slide? I'll go back to this slide real quick. I just want to see where I'm at. Okay. So this is me, and I do all of these things, and I help, if people are interested, in exploring more, I help people learn about their, what their issues are, and go over what they're looking for, and how they can see the value in what the Chinese medicine world, what it has to offer. So let me know if you need any help in exploring this world. And should I go back to that other slide and just kind of leave it up, or are you guys good? Okay. All right, I want to say thank you for letting me speak up here, and I'll give the floor to you, my friend.
Okay, I was told this. We have 8 minutes now or so. Okay, I want to leave a little time for questions so that you can have that if you'd like. So I'm really going to focus on something that has kind of woven its way through all of this, and that is, what is it then when we talk about doulas? And I think I'll focus there. Because there is, actually doula is a term that's so old it looks new. Doula, actually the original definition of doula in its root was a woman servant, and so that's already changed. because I'm doing the work, okay? And it was also just service or being in that relationship with someone to serve. And we know about birth doulas, probably everyone in here does, and that's been around a while. And so now we have come to evolved back to what we've been doing for ever since the age of man, and that is doula being in service of those who are dying as well. So birth and dying doulas. So bookends of life, okay? And so the first thing I want to say, this story popped in because of all the questions and all of what was being told, and I'm going to tell this story. And even if we don't do anything else, I'm going to tell this story because it's about doulaship. There was an elder man, he was a bluegrass musician. I had an opportunity to serve when there was crisis care and hospice, which meant that I could go and spend all day with him, and just he and his wife. And he was in the end stage of lung disease, and he was dying. And we had some time together where we could talk about things. He liked to smoke cigarettes and drink coffee and watch Westerns. That's what he did in his day, and that's what he would do. So we would talk about things, and I would ask him, are you ready? And is there anything that you want to talk about? And he said he was scared. He was very frightened because he watched his parents die of the same thing, and he did not want to suffocate, he said. And I said, well, I believe we can help you. And I said, and we have medication that we use. Morphine isn't always for pain. It's a wonderful drug for medicine for breathing as well. So anyway, I felt okay about the fact that we could assist his comfort. But there was a little question mark I had. And that question mark was, I hope we can. We're going to do our best. I was young in hospice, and I really just didn't know. But we're going to do this. So we moved on in our relationship together over a period of a couple of weeks. And one day I walked in at 7 o'clock in the morning, and he was in a semi-comatose state. In other words, he was restless. He was picking, he was agitated, he was dusky gray is what we would call the color that he was gasping for air, he was staring not at me, that's a bigger view, but he looked really uncomfortable. And so all morning we medicated him to the fullest extent of what we had available to work with him, and it never changed his appearance. But we kept going. And so his wife and I, it was just the three of us, his wife and I and he. He's in the bed and we're doing this, and she is scared, and we are just working with this. About 3 o'clock in the afternoon, he wakes up. I mean, completely fully lucid, wakes up. And we've been using a lot of medicine. So this touches on, do hospice nurses and physicians kill you with morphine? No. We gave him a lot of morphine, but he could tolerate it because of the titration. He'd been on it for a long time. But we gave him maximum doses. He woke up. He woke up so much, and he said, son, do you think you'd get me a cup of coffee? And I said, yes, I think I can. And can you light my, yeah, I'll light your cigarette, and we're back here. Here we are. And so here's what I want you to hear. I had an opportunity to ask him a couple of questions. And the first one was, do you remember me coming in this morning? Do you remember anything about today? And he said, no, son, I don't remember a thing. He said, I was sort of out of myself, you know. And I said, yeah, I thought you might be. And then I asked the question, which was purely for me. Were you suffering? And he looked at me and he smiled and he said, son, I couldn't tell you a bit that I was suffering. Not a bit. I want you to hear that. Because often what we see in our senses and what we're watching We have a definition about how much suffering there is. We have a definition about how terrible this is. We have a definition about a lot of things because it's just our view. It's just our perspective. We have one small perspective. And when I had a man like him tell me, and I watched him all day as a nurse, and I would have told you he was really uncomfortable. There wasn't a bit of discomfort with him at all. So remember that if you don't remember anything else. Okay? Because it's much bigger than you might think it is. It's much grander. It's beyond our physical senses of what's going on. And just remember and he told me I could use his name. He said, oh yeah, tell people. Billy. Remember Billy taught us all that, listen, don't get too sucked in and too afraid about what you're watching, because there's more going on than that.
How do you know whether to medicate or not? Because you were medicating. You don't really know what it would have been like if you hadn't, right? Because you were going on what your view.
I'm going on my assessment, and my view is you're uncomfortable, you are starving for air, you are restless, you're sweating, I'm doing everything I can to assess physically, but it's just a physical, and I don't mean to minimize physical assessment, but that is only one part of us. That's all we have to look at in our bodies. So I'm looking at your body, and I would rather make sure you're comfortable than to pretend like you're not. But he showed me something about, don't get too locked in to the fact that this is all that you think it is, because it can be much bigger, is my experience with him. Now, what that means is doula. Doula is to be in service of, to be with, instead of do to. To be with. You know, to simply be a presence. And how do you do that? Well, you have to prepare for that, because you're coming into situations like this man. And it's important. There was a woman that had a near-death experience when she was 5. She died for 45 minutes, and all that went with it. But I'll say that what she told me was, in her transcendence of her body, she was watching what was going on, and she was looking for help, and she's 5 years old. And she looks over to the park bench, and there's a man sitting there reading a book. And she knows that he's watching her. So she goes over. Now, this is in her out-of-body experience, because her body is dead on the ground. And she says, can you help me? And he goes and helps her. And I said, what was it about him? Because she's studying to do this doula work. I said, what was it about him? And he stayed with her for 5 days of coma. Of course, nobody else saw him. But he stayed with her for 5 days. And I said, what happened? He said, well, he was just there. He was always there. And he was always so calm. And he was so present. And he was so loving. I said, how does that relate to doula to you? And she goes, that's it. Just to be with. And how do you do that? Well, it takes some preparation as humans so that we can be that kind of presence with each other. Doula training is non-medical. Anyone in this world can prepare yourself to be with those in your family or your community or your church or wherever. You can do this if you're willing to dive in to your own self first and know where those triggers are, right? Those triggers. Know where those things are where we get really uncomfortable. Know where those things are for ourselves first, so that we can be with someone else in what Joan Halifax would say would be a state of equanimity, which is this spacious stillness to allow in a loving, compassionate way. You know? Now that's what she learned from this, and that was a teaching for me. It's like, that is where I want to be, in that place.
And not just waiting until we're dying to do that. It becomes, why can't we do that in our life? Just to be that way with each other. That's doula practice. More and more people. Trish is a sacred passage doula. Aditi is a sacred passage doula. The doula training, clinical or not, it is that preparation to be able to stand in the fire with someone without getting burned. Would be another way I'd say it. To just say, I'm here. And it's not leading. It's not pulling them along. Say, come this way. It's not teaching them. How can I teach you how to die? It's not that. So what is it? The way I see it is I'm standing right with you, right close, but I'm just a little bit behind you. I'm just going to go. You know? That's doula practice. There's opportunities to do that for yourself, to train or just to, and it really just points to your life. Death is one moment. Death is, Dennis Hopper said one time, he said his friend told him death was you breathe in and you breathe out. And that's what he did. That's what Dennis Hopper was, and then he just did his hands like that. So that's it. Okay? And there's no more breath in. That's death. Everything else is life. And we have an opportunity to look at our life like that. Is how I see it. And I'm just going to stop there.